Yeah.
Okay. All right. Good evening. Good evening. Can everyone hear me in the back of the room? Okay. All right. Well, thank you for attending this meeting of the Southeast chapter of the Society of Critical Care Medicine. As we do always, we say our mission at the beginning of the meetings, and our mission is to emulate the same mission as the national organization, which is to secure the highest quality care for all critically ill and injured patients through a multidisciplinary approach. So before we get started, I just want to give you guys some quick chapter updates, and then I'll introduce our keynote speaker, and he'll give his fabulous presentation, and then at the end, we'll do a question and answer session. So first, for those of you who are watching in Memphis, we just want to apologize for some of the technical difficulties, and thank you for being patient with us. Okay, so a couple of weeks ago, we had our first annual Spike Out Sepsis event. So this was a volleyball tournament that we did, and we recruited healthcare professionals from all different disciplines. So we had 4 teams, and we had probably a total of about 30 people participate, give or take some spectators. And one of our teams, surprisingly, was a group of sepsis survivors. So that was really neat, and it was very fitting that they won the tournament. So congratulations to them, and we're going to be doing this every year. So we hope that you guys will think about participating next year. We raised $2,000 for Sepsis Alliance to put towards sepsis causes. And we really hope for the physicians in the room. We did not have a physician team, so we hope that you guys will participate next year as well. No names. Okay. So I also want to let you guys know that if you're interested in writing an article for the December newsletter, please just shoot me or Marina, our president-elect, an email, and we'd be happy to review your article and possibly publish that in our newsletter. Also, for those of you who have signed up for the CE or CME credits, on your way out, we're going to have certificates for you. So they'll be on that same table where you guys signed up on the rosters. And then finally, our Barbara McLean Award for Critical Care Nursing is coming up. So nominations are going to be due the end of October. So this is a very prestigious award. There's a monetary prize. You get a plaque. And then your name also gets put on a plaque holder, so we keep track of all the previous award winners. So please think about a critical care nurse that you would like to nominate. So without further ado, it's with great pleasure that I would like to welcome Dr. Adam Webb as tonight's keynote speaker. Dr. Webb's presentation, Brain Death and Update, will illustrate important concepts concerning this particular patient status, which most of you, if not all of you, have encountered regardless of your discipline or your area of specialty. So Dr. Webb's career has taken him through years of study, research, teaching, and administration, particularly within the field of neurocritical care. And after completing a fellowship in neurocritical care at Emory University, he impressed them so much that he was hired as one of their neurointensivists. And he was also given a faculty appointment as assistant professor of neurology for the Emory University School of Medicine. And in February of this year, Dr. Webb has transitioned into his new role and his new well-deserved role as medical director of the neuroscience ICU for the Marcus Stroke and Neuroscience Center. So we welcomed him here at Grady this year. And in addition to his appointments, Dr. Webb has authored several publications in prestigious journals, and he has also authored book chapters. And his research interests include family communication in the ICU and performance improvement initiatives in the neuroscience ICU as well for to improve patient care quality and patient safety. And he also serves on numerous committees at the institutional, regional, and national levels. So let's please give Dr. Adam Webb a warm welcome.
Great.
Thank you.
Thanks, Kat. All right. So thanks, everybody. For those of you who know me, you know that this is a topic that is near and dear to me, and something that I've thought about for some time now, and combines a bunch of my interests both in the medical arena and the political arena and the ethics arena and all sorts of things. And so I'm going to take you through, brain death is, though it can seem simple, it's actually a very complicated topic. And I think the best way to illustrate that is to take you through a little bit of the history of brain death, and sort of where we've come from and where we've gotten to, and talk a little bit about the practical aspects of brain death determination and what it means and what it doesn't mean, and dispel myths and rumors, and then also take you through some of the areas of controversy that, even as I was a resident in neurology here, and this seemed like, of all the things in neurology, this was pretty straightforward. This is pretty well established, and as we've seen over the last couple of years, there really is a fair amount of controversy, both in the medical realm as well as in the media realm and popular realm, about brain death. And I'm going to take you through some of those controversies that are, some are more pressing than others, but to talk a little bit about that. And I think it's important to have sort of an open discussion about that. If at any point in time, we'll have a chance for questions at the end, but if for some reason along the way something's not clear, please let me know. So I don't have any relevant financial disclosures. I do serve as a member of the Professional Development and Clinical Practice Committee for LifeLink of Georgia, mainly helping hospitals with policy development. And I may mention a few of Grady's new policy elements as I go along, but I've helped numerous hospitals in Georgia set up their brain death policies and revise their brain death policies. And I also do education for LifeLink as well. So, as I said, death determination seems like it should be relatively straightforward, yet it's not. And throughout medical history, it hasn't been. On your left here, you'll see a treatise that was published by a guy named Jean-Jacques Winslow, who's a French physician. This was published in 1740, and basically he was a physician who, as a child, has twice been abandoned for dead and awoke in a coffin, and probably had epilepsy. But he had a very personal reason for trying to make sure that medicine had an answer for the question, when is someone dead? And in 2008, you would think we would have solved this, but in 2008, this is a ethics treatise that was published by the President's Council on Bioethics that was really taking up some of the very same issues about when exactly is it appropriate to determine that someone's dead. So this is not a settled issue. The reasons might be different, though. Now we're dealing with this as an issue of organ transplant, as an issue of when it's appropriate to terminate life support on a deceased body. In the 1700s, it was for more practical reasons. And if anyone's ever heard of the condition called taphophobia, that's the fear of being buried alive, which was very real at that point in time. Especially as different plagues made their way across different continents, there was a tremendous fear that people had. And this probably was grounded somewhat in reality, that they may be taken for dead and quickly buried. And this was actually a patent application for a device that you could be buried with, so that if you awoke in a coffin, you would have your hands on this little crank, and you could turn the crank and it would ring a bell above, and someone would know that you were probably not dead, and they should go and retrieve you. So, like I said, the issues were different, but the questions are the same. There have been tools, especially over the 19th and 20th century, that made us think that we may have had this issue solved. The invention of the stethoscope, so we could auscultate heart sounds, and the invention of the electrocardiogram, so that we could actually see cardiac electrical activity. These were solutions that allowed us to definitively say, or we thought definitively say, when the heart had stopped, and when it had stopped irreversibly. Until 1953. And in 1953, one major development happened that actually impacted probably anyone in this room if you're interested in critical care, and this was the development of the first intensive care unit. So the polio epidemic was raging across Europe at that point in time, as well as other places. And a guy named Bjorn Ibsen in the Municipal Hospital of Copenhagen set up what is credited to be the first intensive care unit. And the reason it's credited for that is it was the first place to use prolonged positive pressure ventilation for the treatment of patients with polio that developed respiratory failure as a result of polio. Positive pressure ventilation had been used in the operating room for some time by this time, but it was thought to be something that you could use for a short period of time. And respiratory support for polio victims had been done for a long time, but it was using negative pressure ventilation, or the iron lung. And so there was sort of a merger of technologies at that point in time, and is what's credited as the first intensive care unit. And within a very short time, we began to see descriptions of patients who we would now consider brain dead. So this is the first published report of this. This was 6 mechanically ventilated patients who had a constellation of loss of neurologic function. They also developed hypotension, hypothermia, polyuria, and all of them on a cerebral angiogram had absent cerebral blood flow. And all of them died within a very short period of time and had complete cerebral necrosis at autopsy. And so these are from some of the first descriptions of brain death. The 2 that are actually credited with the first description of brain death was Molleret and Goulan, who actually published a large series of patients, 20-some patients, and these patients met their criteria. They had a complete lack of cognitive and vegetative functions. They had absent EEG recordings, no intracranial blood flow and angiogram, and total necrosis at autopsy. They were also the first to describe what we now know as central diabetes insipidus, which was a huge diuresis at that point in time. They described these patients as being in what they called an irreversible and irretrievable coma. And they were very correct in pointing out that, as they said, such a coma is a price that one has to pay for the skills that we've acquired in resuscitation. And so basically, we've gotten ourselves into this situation where we have patients that have complete loss of brain function, yet they're still being maintained physiologically on a ventilator. In 1959, which is the same year, another report came out that included allowing prolonged periods of apnea in an attempt to stimulate respiratory centers of the brain, which is sort of a precursor to what we now think of as an apnea test. And also, this paper was the first to call this sort of by the name that we call it today, which is I don't speak French, but the death of the nervous system is essentially what they called this. And in 1962, a few years later, so now we're talking about just a short period of time, over 10 years from the first use of the ventilator to now in 1962, in an abstract to the American Epilepsy Society, Schwab and colleagues described these patients as what they called heart-lung preparations, and were the first to propose that these patients may in fact be dead. And that this was actually the first mention of this possibility in 1962. And they were also the first to, and this is amazing, just in a very short abstract, to suggest that our current cardiac criteria for determination of death were probably no longer adequate. So in 1968, what's called an ad hoc panel from mainly faculty members at Harvard Medical School, Public Health, Law School, Divinity School, graduate schools, got together for this ad hoc committee, and their entire purpose was to define irreversible coma as a new criterion for death. And they have this entire published report. It's a short but interesting read. They listed 4 conditions that had to be met. First, the patient had to have unreceptivity, or they had to be unreceptive and unresponsive, no movements and no breathing, no reflexes, and a flat EEG. They recommended repeating all of these tests again after 24 hours. They also recommended excluding hypothermia or any drug intoxication. They recommended consulting with at least one other MD or having someone else to corroborate these findings. And this wasn't for any medical reason. It was mainly for medical legal reasons at that point in time. And if the patients met the criteria, they could be declared dead and taken off the ventilator. They also noted, because the history of organ transplantation was sort of coincident to this, that declarers should not be involved with potential transplantation. I think, amazingly, this entire treatise had only one single reference to it, and it wasn't even a medical reference. It was actually a reference to Catholic religious doctrine that was a paper from a treatise from the Pope that basically said that the Catholic Church believed that death is when a physician says it is, and they use that as justification from a religious standpoint to say that we're saying this defines death, and therefore it should be accepted by religious communities as well. I think it's important to point out with this the issue of whether part of the reason for this at the time was before lots of cases and legal precedents that we now take for granted, which allowed for patients to be taken off of life support if their surrogate decision makers say they wouldn't want to be on life support. And so at that point in time, there was no legal precedent for that, and there was a concern that ICU beds and hospitals were filling up or would fill up with people that were essentially brain dead, that were on ventilators and being maintained artificially. So this was part of the rationale for this, in addition to some of the transplant issues. And this was given some ethical credence in 1981 when the President's, this is the first paper by the President's Commission on Bioethics, when they got together to really back this idea of brain death. And they said, when a ventilator supports the body's vital functions, this technological intervention obscures our view of the phenomenon death. And what seems to be signs of continued life are, in fact, artifacts of the technological intervention and obstacles to ascertaining the truth. To consult brain-based functions, then, is to look through a second window in order to see the actual conditions of the body. And so they basically said that because of mechanical ventilation, this obscures our ability to see death when it's right in front of us. And so we have to look for this second window into looking at it. And the reasons they cited were as to why we needed to update the criteria for death. Part of it was just it wasn't as clear with new technologies. They also, that's the advent of organ transplantation using cadaveric organs or cadaveric donors had really, we needed to be able to decide exactly when someone's dead so that their organs could be retrieved. And so the part of the ethical underpinnings of organ transplantations is what's called the dead donor rule, which basically says that you can only remove vital organs from a patient after they've died. Additionally, continuing to ventilate and intervene on a dead body doesn't give it the appropriate respect and care. This isn't an appropriate use of resources, and also this relieves a burden on family members that they don't have to, continue to make decisions regarding life supportive apparatus and things like this, and they can be relieved of those decisions. And in all of their recommendations, they basically, I think the one that's the most important is that they said that death is a unitary phenomenon that can be accurately demonstrated either on the usual grounds of cardiac cessation of cardiac and lung functions, or on the basis of irreversible loss of all functions of the entire brain. They also advised that this should be incorporated into statutory law, which happened or began to happen that same year. So in 1981, the American Medical Association, the American Bar Association, an organization that tried to achieve uniform state laws for things that were important to have uniform state laws, like you wouldn't want to be dead in one state and not dead in another state, got together and put out what's called the Uniform Determination of Death Act. And pretty much every state in the country now has adopted some version of this, with caveats here and there, that the Uniform Determination of Death Act states that an individual who sustained either irreversible cessation of circulatory and respiratory functions or irreversible cessation of all functions of the entire brain, including the brainstem, is dead, and that a determination of death must be made in accordance with accepted medical standards. And we'll start to talk about some of the controversies now really have to do with what the accepted medical standards are and changes in the accepted medical standards that have occurred over years. So this is Georgia's statute, and I apologize to our friends in Memphis that I didn't include Tennessee's statute in this, and I actually assume it's fairly similar, but it may have some subtle differences to it. Some interesting things I think about Georgia's statute is that a person can be pronounced dead by a qualified physician or by a registered professional nurse authorized to make a pronouncement of death. And the criteria are the same: irreversible cessation of circulatory and respiratory function, or irreversible cessation of all functions of the entire brain, including the brainstem. Interestingly, and this has come up in my practice before, that a person who acts in good faith in accordance with provisions of this code aren't liable for damages in civil or criminal proceedings. And this has not been a common occurrence, but you do run into this occasionally where families will obtain court injunctions against you or attempt to obtain court injunctions to stop you from removing a patient's body from life support after they've been declared brain dead. It doesn't come up much, but it certainly come up on several occasions over the last couple of years in my practice. And so this is fortunate that if I can't be held after the fact liable for any damages in civil actions or criminal proceedings in this. And the accepted medical standards have been published now by the American Academy of Neurology. This has really been the body that's been tasked with providing these medical standards. And this is from their first practice parameter for determining brain death in adults, which I think was published in 1991, and left the publication date off there. But what they state is that brain death is the absence of clinical brain function, important clinical brain function, when the proximate cause is known and demonstrably irreversible. You have to exclude any complicating medical conditions, you have to exclude any intoxications or poisoning. The original core temperature, this is actually the updated core temperature, used to be greater than 32 degrees centigrade, is now greater than 36 degrees centigrade. And the three cardinal findings are coma or unresponsiveness, absence of brainstem reflexes, and apnea. And so I'll take you through how we determine those three things. So coma or unresponsiveness basically means that there's no cerebral motor responses to pain in all extremities. And I point out cerebral versus spinal cord. You can see spinal cord reflexes in this, and I'll talk about that a little bit. There's certain standardized painful stimuli that we use, including supraorbital nerve pressure, TMJ pressure, nail bed pressure, and nasal, what's called the nasal tickle, which is essentially putting a cotton tip applicator in the back of the nasal turbinates, which is an extremely noxious stimulus for patients that have any sort of wakefulness. Less standardized things that we try to shy away from are things like sternal rub or pinching of extremities. That we sometimes will use those, especially if we elicit some sort of movement. We'll want to try to identify what that movement is, where that's coming from. Usually, with determining this, we use multiple stimuli and we document what stimuli we use. Absent brainstem reflexes are a little bit more, I think a little bit more objective. You can have round or oval pupils. They can be mid-position, 4 millimeters to dilated with no response to bright light. It's very important that, especially if patients have 4 millimeter pupils, that that you want to really look critically at their neuroimaging in that situation. And you can sometimes have things that will fool you. And so if their pupils aren't dilated, you want to be a little bit careful, even if they're not reactive. Absence of oculocephalic responses to rapid head turning, absence of cold response to cold caloric stimulation, which we inject 50 cc's of ice cold water in the external ear canal. In doing that, the two ears need to be separated by a few minutes. Absent corneal reflex, absent cough to deep tracheal suction, absent gag reflex. These are the basics. The apnea test is usually the final portion of the exam that we'll do. And in an apnea test, the core temperature, again, has to be greater than 36. You have to be able to achieve a systolic blood pressure greater than 90. Ideally, you can be on pressors, but if you're maxed out on multiple pressors, and that's as good as it gets, you need to be cautious because you may not be able to complete the apnea test. Patients need to be in positive fluid balance or near positive fluid balance, or at least not be in uncorrected DI. Have a normal PCO2 for that patient, and so if they're normally a CO2 retainer, they need to be in their normal range. You need to have, it's helpful to have an arterial line in place because you're going to have to obtain multiple ABGs, and we'll pre-oxygenate patients at 100% FiO2 for several minutes. Usually 20 to 30 is adequate. You want to try to get a PaO2 greater than 200. Draw a baseline ABG, document the PCO2 and the PaO2, and then we disconnect the ventilator for 8 to 12 minutes. And it's very important that when this is done, that the ventilator is disconnected. I've seen multiple attempts at people doing this on a spontaneous mode of ventilation, and ventilators are very sensitive and can auto-cycle frequently, and so it's not appropriate to do these actually connected to the ventilator. What we'll do is to provide what's passive oxygenation. We'll take a piece of either a nasal cannula with the nasal cannula portion cut off, or a piece of extension tubing, and put that down the endotracheal tube so that it sits right about the level of the carina and give between 4 and 6 liters per minute of oxygen. And that's shockingly enough to keep people very well oxygenated for a period of many minutes. You have to maintain hemodynamic stability and look for any sort of respiratory movements. And then after 8 to somewhere between 8 and 12 minutes, I usually draw one at 8 and one at 12 to look to see if the PCO2 has risen above 60 or above 20 above baseline. And if there's no respirations and an appropriate CO2 rise, that represents a positive apnea test that's consistent with brain death. So as I said, there's a number of other clinical observations that are consistent with brain death that are sometimes seen, and these are important to know about just as you may see them. You may have to explain to family members about these, and I often will point out to family members that we expect sometimes that there will be some movements when we're doing our exams, but what we're doing is trying to determine if those movements originate from the brain or originate from somewhere else in the body. So you shouldn't see posturing, because that actually implies the brain is intact at least somewhat. But you can sometimes see spontaneous movements of the limbs or responses to pain. They're usually spinally mediated, and they're usually very stereotyped. They extinguish if you keep doing them over and over and over again. Sometimes during apnea tests, you'll see respiratory-like movements. You'll see patients arch their back, but they don't take significant tidal volumes. They shouldn't be recurrent. You shouldn't see them do it 12 times a minute that suggests respirations or respiratory drive. Patients don't have to be on vasopressors, and they don't have to be in DI to be considered brain dead, and they will maintain often deep tendon reflexes and the Babinski reflex. So a couple of pitfalls, and as I said, brain death is a clinical diagnosis, and it's the loss of clinical brain function that meets those three criteria: unresponsiveness, absence of brainstem reflexes, and apnea, or absence of respiration. But a couple of pitfalls, and these are important to remember, and these are often where a lot of the confusion lies in how we approach brain death testing clinically. First and foremost, you absolutely must know the etiology. That if someone just shows up to the emergency room and their exam is not their exam is consistent with brain death, and you have no idea what happened to them, you must know the etiology. And it doesn't necessarily mean you have to necessarily reconstruct the exact story, but you have to have neuroimaging findings that support this. You need to know a little bit about what the etiology was. Do they have signs of trauma? Does it look like traumatic brain injury? Do they have an aneurysm rupture? Do they have blood in their head? Is their brain horribly swollen from an anoxic injury? Did they have a cardiac arrest? You need to know the etiology, and there needs to not be questions about that. You need to know a little bit from a pharmacologic standpoint about any sedatives that they've gotten or any neuromuscular paralytics. This is more of an issue in patients that have been inpatients for several days. Sometimes patients trauma patients will be given induction drugs or things like that. And you have to certainly allow for clearance of those drugs, but that's usually not as much of a factor with this. And I'll talk about some specific recommendations for that later on. When there are reflex movements, and this frequently happens even amongst people that do brain death testing frequently, that oftentimes when we do see movements, we'll ask another individual to come look at those that's also qualified at looking at these, just to make sure that we're confident that these don't represent brain-mediated movements. Another potential confounder that's come up, and this was something that I've written a lot about, is when patients undergo cardiac arrest and receive therapeutic hypothermia. This was not recognized as a potential confounder until a couple of years ago. And we actually had a patient that had cardiac arrest and was treated with therapeutic hypothermia, was rewarmed. 24 hours after they were rewarmed, their exam was consistent with brain death. And this was confirmed by two neurointensivists, actually, and the exam stayed consistent with brain death for 24 hours. And then I got a call probably 36 hours after the patient had been determined to be brain dead, as the patient had gone to the OR for organ procurement. And it turned out when they arrived there, the very astute anesthesiologist noticed that the patient had regained a cough reflex. And when I went and examined the patient, not only had they regained cough reflex, but they had regained corneal reflexes as well. They didn't regain anything else from there, but they did regain some lower brainstem functions. And so this one thing that this taught us is that in the setting of cardiac arrest, especially when therapeutic hypothermia is applied, that clinical criteria are simply not enough. There's no waiting period that's probably long enough to determine this. And so in these patients, as well as other patients, often pediatric patients, and anytime there's a potential confounder, we turn to ancillary tests. And ancillary tests are also called confirmatory tests. I like to think about them as ancillary tests because it's not that they're confirming something, they're additional evidence that's being used to support a determination of brain death. And so it's important to point out brain death is still, the way we've defined it in the United States, is still a clinical diagnosis. Ancillary testing is not necessary as a part of this currently, but it is necessary in certain circumstances. And so whenever there's uncertainty about the reliability of some part of the exam, or if some part of the exam can't be done, say you attempt to do an apnea test and the patient doesn't tolerate the apnea test, they become too hypotensive or hypoxic, that's a time when ancillary testing is used. Ancillary testing is divided into essentially two camps. on one side of it, and really the only thing that's still on this in this group is tests that look at electrophysiologic function of the brain, and EEG can be used for that. There are some, as I'll talk, there's some challenges with that. The other group of tests are those that measure any amount of cerebral blood flow, and that's cerebral angiography. That is what we call nuclear medicine testing, or nuclear medicine cerebral blood flow testing, and transcranial Doppler. It's also very important to point out that false positives and false negatives in ancillary tests are not uncommon. This happens not infrequently, that we'll see patients that meet clinical criteria for brain death, and an ancillary test still shows evidence of cerebral blood flow. It's also the case, and there's been numerous published cases of this, of ancillary tests being done that show absence of cerebral blood flow in patients that don't meet clinical criteria for brain death. And there's been a couple of very high-profile cases that have been on the news of patients that have been determined to be brain dead solely based on ancillary tests that actually recovered nearly completely. There's a great video that I sometimes play of a guy that came on the Today Show after an ATV accident that it was at a medical center in Texas, and they hadn't gone through the appropriate clinical channels to determine brain death, had solely relied on a nuclear medicine study, and this guy not only regained some brain function, he went on the Today Show. It may not require a lot of brain function, but so this is nuclear medicine cerebral perfusion study. It's called a nuclear cerebral blood flow study, or cerebral scintigraphy. Basically, a IV nuclear tracer is given, and there's a nuclear camera that's placed by the patient's head, and you can see in this that there's tracer uptake that goes to the face and the scalp. But there's this hollow light bulb sign. There's some of the positives of this is it's pretty objective in terms of its interpretation, and it can be done in some centers at the bedside. It requires having a portable nuclear camera, which actually we don't have here, and so and there are multiple institutions that don't have this, and so sometimes these studies will require the patients to be stable enough to transport down to radiology. One thing this is not good at determining is any uptake in the posterior fossa or the brainstem, the lower brainstem, and so we're often weary of using this test in patients that we haven't even attempted apnea tests on, because sometimes you can miss lower brainstem function or lower brainstem blood flow with this, and so you have to be a little bit cautious with this. Transcranial Doppler, probably my favorite test to use when it's used effectively. This is an ultrasound of the blood flow to the brain. And you have to look on both sides of the brain as well as the base of the brain, and you can see a couple of different things. Usually the brain, you'll see good blood flow both in systole and diastole, but if you have cerebral circulatory arrest, often what you'll see is just some blood flow to the brain in systole, and then that blood flows back out of the brain in the opposite direction, so it basically flows the wrong way out of the brain in diastole. So you have reversal of blood flow in diastole, and this tells you that the pressure inside the head has exceeded the diastolic blood pressure, and so at that point, most of our blood flow to our brain occurs in diastole, and if you're not getting any blood flow to your brain in diastole, that constitutes cerebral circulatory arrest. A couple of things that if you wait too long to do transcranial Doppler, you may actually miss the patterns that you need to see. About 20% of patients don't have any insonation windows, and so if you don't see any evidence of any blood flow to the brain in systole or diastole, that you can't actually make a determination of brain death with this, so there's some physiologic limitations. EEG can also be used. This measures the electrical activity of the cortex. There's very strict criteria for when EEG can be used and what needs to be met. And one of the real challenges with EEG is we have so many different electrical gadgets and toys in the ICU now that all of these have electrical interference that happens or attached to people, and you get even artifacts from sweat and things like that. And so EEG can sometimes be uninterpretable in these patients. You'll see too much electrical interference, and so in modern ICUs, EEG is a little bit harder to do without completely disconnecting the patient from everything. But we will use this sometimes if we can't use other modalities. So in 2010, the American Academy of Neurology, so this is 20 years after the original publication, published an update on their evidence-based guidelines. And this process had been going on for some time, and there were a lot of reasons for this. And I think one of the best quotes from this is that because of the deficiencies in the evidence base, that clinicians have to exercise considerable judgment when applying the criteria in certain circumstances. So while we may think that this is a cut and dry sort of thing, it really takes a tremendous amount of expertise in many circumstances to do this. You have to have a great understanding of neurophysiology, cerebral blood flow, the neurologic exam, neurologic prognosis, stuff like that, in order to determine this. And so, while there are certainly straightforward cases, and this is something that we've adopted here at Grady in our policy, that there are certain straightforward cases, often in trauma, where this is very straightforward and can certainly be done by trauma surgeons with expertise in this. That there are other cases, things like in therapeutic hypothermia after cardiac arrest, that really takes a considerable amount of neurologic expertise to accurately do this. And as you can imagine, the consequences of being wrong in this are pretty dire. So the update to the AAN criteria required, or basically asked 5 questions. They said, first, are there patients who fulfill clinical criteria of brain death who recover brain function? And they did a literature search and showed no patients that had been clinically diagnosed as brain dead that recovered brain function. There have been publications since this, one that the patient I told you about that we published, and some other cases I'll tell you about, that call this into question, and we have to, and I'll talk a little bit about that, about if clinical criteria are completely adequate in all these circumstances. They asked, what is an adequate observation period to ensure that cessation of neurologic function is permanent? They talked about complex motor movements that falsely suggest retained brain function, and they affirmed that these are sometimes observed in brain death. Talked about comparative safety of techniques for determining apnea, and they basically said the technique that I told you about, which had been previously published, called apneic oxygenation, is still the safest technique. And also went through, are there any new ancillary tests that can accurately identify patients with brain death? So I want to focus on 2 of these questions a little bit more in depth, because I think they're important. So question 2, they asked, what is an adequate observation period to ensure that cessation of neurologic function is permanent? And the real answer to this is we don't know. And that this is probably circumstance dependent. In the first guideline, the first guideline that I pointed out, basically said that that there was recommended documentation of a repeat neurologic examination after a period of 6 hours, but they acknowledged that this time frame was arbitrary. They said we just picked it. There was no real reason for it. The new guideline basically says that if a certain period of time has passed since the onset of brain insult to exclude the possibility of recovery, they said in practice this is probably several hours, that 1 neurologic examination should be sufficient to pronounce brain death. They did acknowledge that some U.S. states and many hospital policies still require 2 examinations. Our hospital policy has undergone a recent update, and we've basically said in very clear-cut cases of traumatic brain injury, that's where this is very straightforward, that if a patient has a clinical examination that's done by a qualified physician, and we've set up a credentialing process for who we consider to be qualified physicians, and the patients undergo an apnea test that's consistent with brain death, that under those circumstances that's adequate. However, if ancillary testing is required or there's any confounding issues, that oftentimes we'll still have a second examiner and have an expert in neurocritical care or neurology to examine these patients and determine, just to make sure that we've met the burden of proof for brain death. But this has been a huge matter of controversy that's been in the American Academy of Neurology as to what circumstances are probably adequate for one examiner and what circumstances aren't. And there's multiple camps. There's, on one side, people saying, well, we were inappropriately delaying the organ donation process by doing this, and so if we don't have any proof that 2 examinations are better than 1, we'll cut it back to 1. The other side of people, on the other side of the argument, are neurologists who are saying, we certainly shouldn't be doing anything to lower the burden of proof for brain death. In fact, we should be doing the opposite, which is actually increasing the burden of proof, waiting longer to make sure that we haven't recovered this, requiring ancillary testing, things like that. And so I've been a course director for a course for the last couple of years at the American Academy of Neurology, where we basically have done a brain death sort of controversies panel, and we'll get panelists that are on either side of this to argue this, and there's compelling arguments on both sides, and it's going to be interesting to see what we as a professional society do to answer this question. The last question is question 5. Basically, are there any new ancillary tests that we can use? And the answer to that was no. There have been a lot of people that had wanted to use CT angiography as a surrogate to catheter angiography, and basically CT angiography is not at the point that it needs to be in order to do this. We also cannot use MRI or MRA or BIS as a ancillary test that just simply is insufficient evidence, and actually some evidence as to the contrary that these are useful in that setting. It's not to say that we don't get these tests, but it's just to say these can't serve as ancillary tests. They also clarified a little bit about sedation and confounders. The 2010 update basically says that to exclude the presence of a CNS depressant drug, you have to use history, drug screening, and calculation of 5 times the half-life, assuming normal renal and hepatic function of anything that has been given continuously, and so, or even for something like propofol or fentanyl that's given for induction. For neuromuscular paralytics, it's usually pretty easy because we can do a train of 4, and if patients gotten their train of 4 back, that they don't have any significant drug effect still on board. However, they did acknowledge that the prior use of hypothermia after CPR for cardiac arrest can certainly delay drug metabolism, and so this is a potential confounder that would require ancillary testing. So I'm going to turn now a little bit to conversations with families and what we do. Talk a little bit about organ procurement organizations, specifically LifeLink, the organ procurement organization we work with. So it's explaining to families the concept of brain death is not easy. And explaining that to them at a time when their loved one is dying or dead is especially hard. And that's compounded by the fact that this often comes, with sudden tragedies like trauma or, massive brain hemorrhage, stuff like that. And so families are not prepared to hear about this. But it's very important that we talk to them about this. And it's very important that we prepare them for this before this testing begins. This isn't something that you want to come to a family and say, oh, by the way, we just wrapped up testing, your loved one is dead, and we're going to be, taking their body off the ventilator here in the next few minutes. So this is something that you really have to, the onus is on us to provide good family communication. We have to explain the entire process to families, talk to them about who's going to be involved, what's going to be involved, what we're going to do, why we're doing it, make sure that they know that now's the time to get additional family members there. And also acknowledge that sometimes families are going to elect for palliation and elect for termination of life support during this process. And this is something that's come up more frequently, especially as hospitals like Grady and like Emory have had more, I think, involved palliative care services, that we actually found that we were doing such a good job of talking to families about their options that often families weren't eventually presented with the option of organ donation down the line. And so that we were transferring patients to inpatient hospice units, or families were electing for termination of life support before they had ever heard about options for organ donation. And so this has been something that we've had to balance good palliative and end-of-life care with making sure that if patients would want to have their wishes for organ donation fulfilled, that families know how that impacts their options. Along with this, we prepare that patients can have circulatory arrest during apnea tests, and we don't mince words. Brain death is death. It's not a bad prognosis. It's not it's not something. It's death. And then that's what our statutory definition of death says in the United States, and that's what's accepted medical practice in the United States. And after that, we never imply that families need to make a decision about termination of life support. Once a patient is pronounced dead under state law and under any hospital's policies, that at that point in time, that patients can be taken off of any sort of mechanical ventilation, vasopressors. There's no medical, legal, or otherwise reason to keep them on that. In fact, it's many considered inappropriate. We wouldn't take a dead body and hook them up to a cadaver and hook them up to a ventilator. And there's no reason we should continue to do this with patients after they've been pronounced brain dead. Other things that are very important is documentation. When we document this, the etiology and the irreversibility of the condition is important, that we excluded confounders, all the things that we did. If we did obtain ancillary tests, why we obtained ancillary tests, what part of the exam was not reliable. And the time of death is always listed as the time that brain death is declared. If it's not listed, it's not the time the patient's heart stops after the body's taken off of mechanical ventilation. It's not the time that the patient goes to the operating room for organ procurement. It's the time when brain death is declared. So a little bit about when to call LifeLink, who's our organ procurement organization. Basically, any time a patient's on mechanical ventilation, regardless of their age, their diagnosis, if they meet any of the following criteria, this should prompt a referral to LifeLink. If they're not on sedation and they exhibit 2 out of the 3, either absent corneal reflexes, absent cough or gag, fixed and dilated pupils, and have some sort of severe brain injury, that should be an automatic prompt to at least let LifeLink know about this patient. If there's any discussion of brain death testing with a family or discussion of termination of life support for that matter with a family, that should prompt a referral to LifeLink, at least to notify them and see if they want to have a chance to approach a family about organ donation. And certainly if a family requests information, this happens very frequently, if a family requests information about organ donation, that this should prompt a referral to LifeLink. Because there are now opportunities for organ donation outside of brain death. And the best people to talk to about that are LifeLink. It's very, very important that the medical team maintains we have a commitment to the patient, and we have a commitment to treating the patient as a patient and not as a potential organ donor. That doesn't mean that we treat them as a patient to the exclusion of their possibility of being an organ donor. It just means that we have to draw very clear lines about whose job is what in this process. And the role of the medical team is to identify potential candidates and refer them appropriately to an organ procurement organization to make sure that we help families understand what's going on, the process of brain death determination. We're obligated to determine if a patient meets brain death and pronounce death when that's the case, that we don't delay that, and that we maintain supportive care until that time if it's appropriate. LifeLink's role, or any organ procurement organization's role, is to determine whether someone's a suitable donor. That's not something the medical team does, that's something that LifeLink does. It's their role to approach families and discuss options for donation. It's their role to obtain consent for organ donation, and then maintenance of supportive care after brain death has been pronounced if the patient is going to be an organ donor. So I'm going to wrap up with talking about some controversies, because I think this is important to recognize, as I said, that this isn't as cut and dry as it may seem. So in 2008, the President's Council on Bioethics basically published a revision and an updated ethical analysis of our ethical criteria for brain death. And they cited 4 things that they thought were concerning that needed to be sort of further thought about and discussed. The first was confusion about the term brain death and its relation to death of the human being. The second was just direct dissent from the medical, from certain individuals and parts of the medical community that brain death in fact represents the death of the human being. And so the whole idea that brain death is equivalent to death was being re-examined. The third was published evidence of ongoing integration of bodily activities in patients who meet criteria for whole brain death or clinical brain death, and deciding is that part of the initial rationale for why brain death was equated with death was that essentially that if it's like taking the steering wheel off the car. That the brain drives all the vital functions and it regulates the vital functions, and that if that goes away, those vital functions, those integrated functions, will eventually go away. And that there have been published examples of when that may not have been the case, and they needed to examine those. And then the last was sort of on the opposite of things, which was pressures against insisting that patients must be declared dead to be eligible for organ donation. And I can give a whole separate talk on the topic of, do I have to be dead to be an organ donor? And that may be something that's changing in the United States. That there have been a lot of people, very smart people, and very credible people who are advocating for a slightly different position on this. So the question of brain death itself and what it is and what it's not. So brain death is not the cellular death of the entire brain. In fact, people that are pronounced brain dead based on clinical criteria may certainly have cellular activity in parts of their brain. And that's not, neurologists and the American Academy of Neurology, and no one refutes that. It just says that that's not, our definition of brain death is not you have complete cellular loss in your entire brain. It's that you have loss of the functions or the observable functions of the brain. And all functions of the entire brain don't have to be extinguished in order to meet the neurologic standard. And so this comes up frequently when we think about patients who aren't in central diabetes insipidus. And so if you lose all functions of the entire brain, theoretically, you should lose all of the functions of your posterior pituitary gland. That's actually not the case in some patients that meet clinical criteria for brain death. And so has been some dissent about that, but this was acknowledged that these are the main functions of the brain, which are consciousness, brainstem function, and respiratory drive were the sort of key functions that were important. So the idea of somatic integration, so the idea that the brain is the integrator of all of these different activities, that this was the original rationale for why brain death was equated with death. And there have been multiple published cases of certain physiologic mechanisms that continue to happen after brain death occurs. And this was observed in some, especially some pediatric cases where pediatric patients had been observed for a long period of time after a determination of brain death for one reason or another. And there's certain things that go on. The body continues to heal wounds, the body can maintain its body temperature. It will continue to fight infections, it will mount febrile responses, that children will undergo proportional growth and sexual maturation if their bodies are kept going long enough after a determination of brain death. And this was one of the things, and that really was a question that was asked that I think was an important one. It says, can a child be born to a mother who died 6 weeks earlier? And this is sort of an odd question to ask, but there have been multiple reports of mothers who have been determined to be brain dead, usually after traumatic brain injury or large brain hemorrhages that occurred during pregnancy, where the mother's body was supported artificially for a prolonged period of time, and they gestated even healthy fetuses after this time. And so this was probably, I mean, I think that everyone can agree that gestating a fetus to, taking it to term or near term is really an integrated function of the body, and that is probably not a good rationale for why brain death should be considered death, because this is an integrated function of the body that can go on after brain death. And so this led to a different sort of ethical underpinning for why brain death is death. And it's one that's not been satisfactory to a lot of people. A lot of people in the ethics community look at this and say, this makes even less sense than the original definition. And this is the idea that what they described as the vital work of the organism. And in their words, this is from the President's Council on Bioethics, the work of the organism expressed in its commerce with the surrounding world depends on three fundamental capacities: openness to the world, or receptivity to stimuli and signals from the surrounding environment, the ability to act upon the world to obtain selectively what it needs, even if that's something as simple as air and oxygen, and the basic felt need that drives the organism to act this way, so that we have a drive that we need to get oxygen. And so it's these basic functions, this vital work of the organism, that is lost in brain death, and this is why it equates to death. So, yeah, and that basically the patients that meet clinical criteria for brain death don't have this. And so this is the current ethical underpinning in the United States for why brain death equates to death. And I'll leave you all to your own thoughts about whether or not you think this makes any sense or not. But there's a lot of people that say it doesn't make a lot of sense to us. And the final controversy is how we do this, how we determine when brain death has occurred. That I've said that there's been changes in the American Academy of Neurology guidelines and in bedside tests for determination of brain failure, that we have a lot of uncertainty about what represents an adequate time period for determination of brain death. There's uncertainty as to when ancillary testing should be required, and some people advocate that it should be required in every case. And also a lot of variability amongst institutions, even leading institutions that have world-renowned neuroscience programs have very different standards for how they do this on a hospital-to-hospital basis. So as we saw, most state laws just dictate that this be done in accordance with accepted medical standards, and the actual policies are left up to individual hospitals. And so there's variability in who does this, what needs to be documented, how it can be done, how many exams are required, what sort of waiting period is required. There's no consistency in that amongst or across institutions. So I'm going to leave you with talking about some controversies that have happened in the last year from this. And these are are still ongoing. Some of these are ongoing and developing. And so Marlise Munoz was a young woman in Texas who, many of you may have heard about this story, who was pronounced, she was actually an EMT and was in a car accident and was pronounced, I think it was a car accident, and was pronounced brain dead, but she was pregnant. And Texas law actually stated that no one could make the decision to terminate life support in a pregnant individual, and so she was actually, her body was maintained on life support, gestating a fetus that they had actually determined was not going to be viable for some time, for a considerable amount of time, against her family's wishes. And this set off a huge legal battle in Texas as to really who controls the decisions regarding termination of life support in brain dead individuals, certainly in Texas. The second case is that of Jahai McMath, which has been for a time from Thanksgiving of last year through like March, was all over the news for a long period of time. And Jahai was 13 years old, and she was at a children's hospital in Oakland, and had gone in for a surgery, a palate surgery to correct obstructive sleep apnea. And had a bad surgical outcome, and had an airway obstruction, had profuse bleeding that happened in the recovery area, and had a respiratory and cardiac arrest, and had an oxic injury. And this was probably started off as an example of a team not doing a good job in allying with the family and communicating about brain death. And this was a case where there was a court injunction against the hospital that prohibited them from taking her off of her body off of life support after she had been pronounced pronounced brain dead, and then ultimately ended up in this bizarre situation where she was pronounced dead, yet her body was given over still on a ventilator to her mother, to the custody of her mother, who arranged for her body to be taken to a facility in New York. And the courts had brought in all sorts of expert testimony about whether and multiple neurologists from outside and independent people had observed her, and everyone agreed that she met clinical criteria for brain death. And so this was sort of a bizarre situation where her body was still on a ventilator, and it was given to the custody of her mom, and she was taken to New York. And then no one heard anything for a while. There was also a battle about if the hospital was required to, if the family wanted that she didn't have a tracheostomy or a peg tube, and was the hospital required to do this? And the hospital said, we're not going to do this. She's dead. It's not appropriate to do this to a dead body. And her family said, well, you have to do this because we can't transport her without this. And it was just a whole drawn-out battle. And just this week, this popped back up in the news. In that there was this attorney who had been working with her family actually released a video to some people in the press that showed whether or not she might be questionably moving her extremities to command. Now, almost a year after this injury. And also showing signs that, and it wasn't established, I don't think at the time, that she had cerebral circulatory arrest. It wasn't required that be established in her case. But they have released also results of some tests that have been done at this institution in New York, that have shown, at least by their reports, some cerebral activity and some preservation of brain structures. And so her family and her attorney are actually going back to the courts in California to essentially have her declared not dead. And so that's the court battle that is about to play out. And this is from People Magazine from Sunday of this week, and from CBS News from last week. And as many people, a lot of neurologists and medical ethicists are very nervous about the outcome of this case, because this, either one of two things happened. This basically, so if she has regained some brain function, either the criteria that were used and the people who determined her to be brain dead were wrong, and they missed something, or they did this inappropriately, or this gets at the entire question of, are we able to determine when brain injury is truly irreversible? And if that turns out to be the latter of these two things, this is going to be a huge area of open controversy that's going to come up. And so I just point these out just as to show that these issues are very sort of healthy and alive in our public debate in the public domain, and that will continue to be debated. So that wraps up my talk. There's 2 reviews that are up here if you want to write down these references. The first is actually a great book by a colleague of mine, Robert Trug, who's he's actually he's an advocate for a very sort of esteemed ethicist and pediatric critical care physician who advocates that brain death is not the equivalent of death. But he advocates that we should be given the choice to donate organs even if we're not determined to be brain dead, that there's a legal and rational and ethical argument for why we can do that. And the second is by James Burnett, who's a medical ethicist and a neurologist, I think at Dartmouth. And he has a great, Nature Reviews of Neurology, has a great article on the controversies in defining and determining death in the critical care world. With that, I'll stop and take questions. Yes? Thanks.
Organ donation, but we've had situations where they refuse, they just wanted to keep them on the vent for 2 hours until someone else comes.
Yeah.
It's kind of like the person is dead, but the hospital is they don't push forth the issue with them because of the situation. But it gives the staff kind of a mixed message.
Yeah.
That will allow the person to, sometimes it's been like a day or 2.
Yeah. How do you deal with that? It's a hard situation, and for the folks that are in Memphis, the question. Yeah, the question was in situations where someone is determined to be brain dead and they're either not a candidate or family has not consented for organ donation, yet they're waiting for another family member to arrive and they request keeping a patient on the ventilator for some period of time until that family member arrives. What do you do? And is there is there an answer for that? And there's not a definite answer for that. There's no legal obligation that you have to keep the patient on a ventilator, but that doesn't mean that if you've created a good therapeutic relationship with the family and you've explained this process, that doesn't mean that there's not sometimes a reason why someone may not want that to occur, and that it's a reasonable thing, I think. And so we usually encounter it on a situation by situation basis. The situation that you have to be careful of is the sort of at the 11th hour, the sudden person who's flying in from across the country, and so that's why starting these conversations early and saying, get everyone here now, and if they say at that point in time and before you've started brain death testing, hey, patient's brother is coming in from California, their flight doesn't get here till 4, would it be okay to keep them on a ventilator for a couple of hours after that? Usually if you've established a good therapeutic relationship with the family, that's not an unreasonable request. But you also don't want to get into a situation where and usually when we do that, we'll say, well, we'll do that, but if the patient's, if they've been declared brain dead and their physiologic status is sort of unraveling, that we're not going to stand in the way of cardiac death at that point in time, obviously. But to continue a current level of support is maybe ethically and socially the right thing to do for a short period of time in certain circumstances, but there's a lot of discretion as to what's appropriate circumstances and what's not. And so that's usually can be resolved just by good discussions, but sometimes it's a challenging thing. Other questions? Yes? Oh yeah, sorry.
Can you talk about the level of transparency with the events for calling LifeLink?
Yeah.
In relation to discussion with the family about organ donation from the physician's standpoint. The reason I ask is several times I've found that we're working toward a brain death declaration, and lo and behold, I come in the morning and LifeLink is there, and it's this sort of awkward situation where we weren't aware and hadn't had a chance to maybe talk with the family about that.
So So the question is, what is the appropriate level of transparency in communication with the family and the appropriate sequence in communication with LifeLink to make sure that everything sort of flows appropriately? And the best answer I have for that is first and foremost, get LifeLink involved early. Get your organ procurement organization involved before, not when you're determining brain death, but as soon as you think it might be possible that this patient is going to progress to brain death, or you're about to start testing, or as soon as they meet those criteria, let LifeLink know, because that gives them ample time to get there, evaluate if the patient has any known wishes about being an organ donor, are they suitable for that, so that there's not this rush at the end, so that everything's trying to occur in sequence. And so I think having a good good relationship with your organ procurement organization and just involving them early is the most important thing. In terms of transparency, so LifeLink has instructed us as a medical team not to mention at all to families that they're coming. That they have said, and the reason for that is that any mention of that may actually detract, and this has been well shown, that any mention of organ donation by the treating team actually decreases the likelihood that a patient's family is going to consent to organ donation. And that's been well shown. And so they want to be the first people to even mention it to the family. Now, if a family mentions it to you, then what you do is you say, that's not part of my role, but what I can do is put you in contact with an organization called LifeLink, and they'll talk to you about those options. But what they'll usually do is that if you contact them early, that they will come in, they'll assess the patient, look and find out, is the patient even a candidate for organ donation, and do they have any pre-existing wishes? And then LifeLink always asks us, is it okay if we approach the family at this point in time? And usually, if you've been transparent with the family about what you're doing and that brain death is going to occur, you're testing for it, the patient doesn't have to. You don't have to have completed the determination in order for LifeLink to talk to the patient's family. In fact, it's oftentimes better if you haven't gotten to that point. But they will always come to us and say, are you okay with me talking to the family about this now? And the only thing that really needs to have been communicated to the family by the medical team is simply that we think the patient is brain dead or might be brain dead, and that we're pursuing testing to establish this is the case. And they don't want us to say to the family, and someone from LifeLink is going to be coming to talk to you about this. They want to be the first people to approach the family. Hey. So the question is, to summarize it, what role can CT scanning and CT angiography play in the determination of brain death, and can they be, what is their role potentially as an ancillary test? I'll separate those two things. The first is non-contrast head CT can be very instrumental in documenting what the brain injury is. And so if you have a normal head CT and you have a patient that looks clinically brain dead, then you need to think really critically about what's going on, because you may not have a good understanding of what's happening. And so the non-contrast head CT tells us that there is irreversible injury to the brain. Global cerebral edema, massive brain hemorrhage, whatever it is, it demonstrates what the injury is, and sometimes shows the irreversibility, though pictures don't necessarily imply irreversibility necessarily. CT angiography has been looked at pretty extensively now in comparison to catheter angiography, and the challenging thing with CT angiography is it's just not, it's a static study. The pictures you get are a fixed moment in time, and there's a lot of things that can still go wrong from poor contrast injection to the patient has low cardiac output and the timing is off. And there just are a lot of confounding things that can miss minimal blood flow in CT angiography, that it just isn't sensitive enough for that role. And it's been looked at. Could that change in years to come? It might, but so far it just has not been able to meet that standard. That if you compare it to other gold standards like nuclear cerebral blood flow testing or transcranial Doppler, that you will pick up blood flow on transcranial Doppler in patients that look like they have no blood flow on CT angiography. More questions? Yeah.
Has anybody looked at, you obviously talked about the inadequacy of the testing you have now. Has anybody looked at like biomarkers as a possibility?
So yes, there's constantly a quest for that, and biomarkers have been very disappointing in brain injury in general. That they have been very disappointing in terms of establishing even severity of brain injury, presence of brain injury, and so the thing that biomarkers have a hard time doing is proving irreversibility. And so if we can't prove that brain injury exists or that it's severe, we certainly can't prove with a biomarker that it's irreversible.
And my last question, so obviously the big pressure for us to determine brain death is the need for donation, right? Critical organ. Say we advance technology, we can clone or do whatever we can to get it. I mean, does that change our definition of, or the urgency behind brain death? And if so, are we addressing the wrong question that, with this whole brain death?
So the question is, if organ donation was not such an issue, that if we had an endless supply of organs from whatever artificial source, does that take away the need for brain death as a medical and legal and ethical construct? And the question is, it changes it a lot. It certainly probably changes some of the urgency. I don't think it takes it away because there's still there still is a reason to determine that someone is dead, even if you're not going to potentially transplant their organs, both from a resource utilization standpoint and also from just what is an appropriate way to treat a dead body, and that is it appropriate to continue to intervene on someone when they're dead. But it certainly would change the public debate about this, because if we say this case with Jahai McMath does point out that say the outcome of this is they say, these people did everything right, and that we clearly have it wrong. We can't determine, at least under these circumstances, the medical profession can't determine irreversibility of brain injury, and therefore we have to call into question the entire concept of brain death. Well, the very next thing that happens after that is that there are suddenly no transplantable organs outside of living-related kidney and liver donation in the United States. And that we are very reliant on transplant medicine in the United States, and I think there would be a huge public outcry about that if that were that were the choice of preserving brain death versus preserving organ donation. And that's where actually people like Robert Trug, I think, that's where they may have an argument that's important and meaningful. And like I said, these aren't wackos. These are he's the head of medical ethics at Harvard and is a very well-established physician in pediatric critical care that's saying, this brain death, this is not the angle that we need to take on this. That there are, we can actually increase our supply of transplantable organs and not have to toe this line about when exactly death occurs in order to achieve that. So, but I think it's a valid question. I'm sorry, Lizette, say that again. Oh, with the Jahai McMath case? So they could, and that's one of. So the question was with the Jahai McMath case, are these movements that they're describing, could those be spinal cord reflexes, still at this point in time? And the answer is definitely yes. So spinal cord reflexes, if the spinal cord's intact, will be preserved for a long period of time. that shouldn't happen in response to command. Yet the one thing that a lot of people have said is no independent examiners have actually had the opportunity to examine her. That this has been videotape that has been given to the press by her attorney from this Institute of Neurologic Injury in New York that has long had a slant against brain death, and so it certainly is it's a potentially biased argument without full information yet. I mean, I certainly don't want to judge one way or another at this point in time because we don't know. So.
How would that determine that they actually be accurate when doing a brain death examination? If someone for example, gives a lack of reflex.
The question is, how do we know when these patients have these spontaneous movements that are reflexive spontaneous movements? I think the question you're asking is, how are we certain that they're reflexive? And the answer to that situation is that's where it takes a considerable amount of judgment, and that's why I got a call probably 2 weeks ago from Vishal Patel, one of my colleagues, who's very qualified and very good at this and has pronounced brain death a lot, and said, I saw something I'm not entirely sure about and I'm not entirely comfortable with. And I think that's, what that takes is humility on our part to say, I'm seeing something I'm not sure about. I'm going to bring in someone else and see if they feel more confident about this, because it is a difficult thing. And as I said, it's something you don't ever want to be wrong about. And so if, sometimes, and we've had this as the case where we've said, what, I don't feel comfortable, that these are definitively reflexive movements, and therefore I'm not going to proceed with brain death testing. Maybe in 24 hours, we'll see if they're still there. But I don't feel that, clinically we can proceed at this point in time because I just don't feel comfortable that these are reflexive. Yeah. Yeah. So the question is, what about the patients that are not quite brain dead, but we think they're going to progress to that point, but along that road, families decide about termination of life support, and this is a very real issue, and so I'll tell you about the experience that we had at Emory Hospital when they built an inpatient hospice unit there, and we had a very very good palliative care team that was very involved in counseling families through these decisions. And actually, after in the months after we opened this unit, and the year after we opened this unit, our LifeLink, our organ procurement organization, came to us and said, "What's happening? We used to have lots of referrals for brain death, and all of a sudden we're not having any." And we started to realize that this was happening a lot, that patients that we were bypassing that. And we as physicians have a statutory and ethical obligation to call LifeLink if we think that someone's brain dead. But if it's before that point, what is our obligation? And I think that we all got together and talked about this and said, we think that it's important that people, just like people have the right to decide what they want to, what their options are in terms of termination of life support, we also think that people should be given good information about what their options are in terms of organ donation. And so what that prompted us to do, and this again gets back to when do you involve LifeLink, and the answer to that question is as soon as possible. Even if you're thinking about, if you have a patient with brain injury and you're considering termination of life support, or you're talking to a family about it, get someone from LifeLink there to talk with them. And even if they're not brain dead yet, at least they can talk to the family. And sometimes what they'll say is, well, would it be important for your loved one to be an organ donor if they could? And if the family says, yeah, I think that would be important. Then what LifeLink does is they say, you know what, let's set a timeline. We're not going to, no one wants to drag this out forever, but let's give things another 24 hours. And if they progress to the point of brain death, then that they can fulfill that. If after 24 hours they haven't gotten to that point, that's at that point, their wishes for not to have artificial prolonged life for a period of time would outweigh that possibility. So it's a balance, and it's something that just takes lots of open communications with families. And if a family comes to me and says, I absolutely, we want to terminate life support right now without question. We're ready. We're all here. Let's go in there and do it. I'm not going to say, I'm not going to do that until LifeLink has had a chance to talk with you. But I might say, can we delay? I'd like for someone to come and at least talk with you about your options for organ donation. And usually if you sort of have a sense of where things are going, there's time for that, especially somewhere like Grady where we have an in-house representative that's here most of the time. Someone can be there to talk to a family within an hour most of the time, and that's usually enough time to at least allow that to occur while you're readying for certain things. And sometimes we've had families that have said, what, actually, yeah, that would be important to us. So let's wait for a period of time and at least see, and they're at least given that opportunity. Yeah. So the question is in the Jahai McMath case, is that the longest that somatic support has been provided for a patient that's been determined to be brain dead? And the answer to that is no. There's been a couple of pediatric cases, actually many of them in California, oddly, of a patient that was maintained for years. It was a young boy, and there was a guy by the name of Alan Schumann, who's a neurologist, a pediatric neurologist at UCLA, who has written multiple articles on prolonged support for brain dead bodies and what happens to them over that period of time. And he was again affiliated with another institution that's I think didn't share in the belief that brain death constituted death, and they would allow for prolonged somatic support. And so he observed this, and he's actually been, a strong advocate against the position that brain death is the equivalent of death.
I think it's really interesting because I've been taught more than one occasion that if you are truly brain dead, that in 7 to 10 days you will have cardiovascular collapse, and then
yeah.
it will not be a question anymore.
And that was the teaching even when I was a neurology resident. That was what was taught to me, and that's clearly not the case. And that that has changed as critical care has changed, and that we now have the ability to do things better than we were ever able to do. But it is not the rationale for why brain death is death. That sort of somatic integration argument really has been called into question, and people said that just doesn't hold water because there's lots of published cases of bodies that have been maintained for a long period of time after that. Anything else? Good. All right, thanks.
Thank you so much. Thank you, Dr. Webb. That was really a fascinating